everybody, and thank you again for inviting me to this session here in Frankfurt. It's always a pleasure to be here and to review data and to discuss my own opinion, our opinions. Not everything is clear in CML. We need to discuss, we need to debate, and we know that the situation in worldwide in several countries is different. Therefore, we need to acknowledge this point, and that's, I think, very important that you all came here. People from more than 60 countries. It's really, really amazing. And I want to thank you for all your work from our perspective, from the doctor's perspective. It's very, very important what you do, and thank you all for your work in all your countries and in the combination of all the countries. That means we are global people, and we should think globally, and it's really important to discuss issues which are of interest for patients in all countries together. So, thank you very much, but I was asked to discuss treatment-free remission, what we know, and what my personal opinion on recommendations is. This is it's difficult because you will see in the discussion that recommendations for everybody globally are different from personal recommendations, what you do with your own patients when you feel that you have the infrastructure to discontinue treatment. And you all know that's open, no need to hide this, that I have two patients who are here who discontinued both. That means the question, would you discontinue outside of clinical trials, to me is really difficult, because I have to say yes, because I did it in several patients and I revealed this, and Jan and Giora can discuss their own perspective on that, of course. But recommendations for everybody are different, therefore I think we should review what we know. We established this scheme of response when we invented quantitative PCR for the use in CML. That means we were not happy with complete cytogenetic response only. We wanted to achieve more, and we wanted to measure more, and we knew from all the studies that if a patient is in MMR, he is on a safe haven. That means for survival, it's very rare that such a patient may progress to accelerated phase and blast crisis. That means that's our first step, and that's very important for the discussion with the patient. Everybody is now talking about discontinuation and treatment-free remission, but we know from from studies that the minority of patients only is able to achieve that, and we must not forget the majority of patients who is in the safe situation with MMR, but is not able to discontinue. And I think I have the opinion and I have the feeling that we forget this majority of patients in our current discussions. And I think this needs to be acknowledged and needs to be discussed, because there is still from 2017, from the perspective of 2017, the majority of patients who needs lifelong treatment. That's fact. It may change over the years, but that's our current situation. But there are, of course, disadvantages of TKI therapies. There is the occurrence of chronic low-grade adverse events which impair quality of life, and we all know this. We will discuss this in the afternoon. There is a risk of inadequate drug compliance and poor clinical outcome when these ongoing side effects are present. And the aging population may take additional drugs which interfere with the tyrosine kinase inhibitors, which may create a problem. And of course, for the younger generation, there is no option of TKI treatment during pregnancy. This will be discussed by Professor Everly later. There's a negative impact on growth in children, at least for imatinib, but maybe the case for other tyrosine kinase inhibitors as well. And of course, there are the cost implications. Therefore, and with the situation that a minority of patients achieved a negative PCR, that means it was called 10 years ago complete molecular remission. Now it's undetectable PCR able with this exponent 4, 4.5. That means molecular response 4, 4.5. With this situation, our French colleagues started in 2007 this famous study, the STIM trial, with 100 patients who were PCR negative and discontinued treatment. And the current situation is that 38 of these 100 patients are still in molecular remission. The definitions have changed a little bit, but that's the overall situation. Then after that, we started EuroSki, a European study with more than 800 patients. We have improved our ability to measure residual disease with quantification of the deep molecular response, and we defined accurately what was the entry criterion for the study, at least a 3-year treatment period and at least 1 year in MR4. There was a screening phase, and then after discontinuation of treatment, a very, very frequent PCR, and if everything was okay in the first year, the PCR was changed to a 3-monthly PCR later. And this is the result. Very accurate definitions. The result is eventually the same. 50% of patients are stable in molecular remission. You see a gradual decrease in this line. It depends on the different definitions, because the loss of MMR was here the criterion for relapse. These are the countries participating in this study. That means it was a real European approach, and these are the main results from the statistics. We looked for the association of specific parameters with the chance to remain relapse-free. First was the duration of treatment with imatinib in most cases, also other tyrosine kinase inhibitors. Means the duration of the active treatment, but also the duration of the deep molecular response. That means it was not, since these patients came from so many countries and from a retrospective situation, of course there was no harmonized duration of deep molecular response. Some patients had 3 years, some patients 2 years deep molecular response, other patients even longer, and this duration was associated with the chance for being relapse-free. And also the duration of interferon-free treatment, but this is, in my opinion, an artifact, because patients who received interferon were patients who had a long-standing duration of CML. That means these were the best risk patients, the patients with the best chance to discontinue, have nothing to do with interferon in the past. Interferon, you learned this yesterday from Andreas, may have an active role when you give it now, but the 10 years ago interferon may not play a role, but this needs to be discovered in this data set. There was no significant association with age, with gender, with depth of molecular response. It means, surprisingly enough, MR 4.5 was not different from MR 4, and any so-called euro or whatever prognostic parameter. These are examples to demonstrate that the duration of treatment is important. These curves show, the blue curve shows patients who had treatment less than 5.8 years, and the red curve shows patients with a treatment more than 5.8 years, and you acknowledge the significant difference of these two curves. It does not mean that we recommend 5.8 years as the minimum. It just demonstrates that the duration of TKI treatment is important. And this curve shows a gradual increase of the chance to stay relapse-free over time. With each year of treatment, of longer treatment, you increase the chance of staying relapse-free by 16%. And that's important for the discussion with our patients. It's very important that we don't have a black and white situation. We don't see after 5 years you are safe, 100% relapse-free, but 4.9 years you are 0% relapse-free. That's not the case. It's a gradual increase. Therefore, we can recommend minimum numbers, but we cannot recommend an absolute 100% chance to be successful with this relapse, with this situation. Duration of MR4, same situation here. The cut point is 3.1 years, more or less. That means you see with a longer duration of deep molecular response, the chance of staying relapse-free is better. Adverse events are, of course, a matter of concern. This was discussed or was first reported by our Swedish colleagues, and it's now the situation in most of the trials that more than a quarter of patients may experience musculoskeletal symptoms, which are called TKI withdrawal syndrome. Now, it's maybe severe in some cases, but in the majority of patients, it's grade 1 and 2 only, but it's of course a matter of concern. In the beginning, some patients who were well trained had the feeling that they had blast crisis, because you have a very similar bone pain in blast crisis, and when a patient learned this from the internet and from literature that advanced disease may create musculoskeletal or skeletal pain, then there was this anxiety, but this was fortunately not the case. What about the second generation inhibitors? This was a study organized by Novartis. All patients had first-line nilotinib, achieved a deep molecular response, and there is another prerequisite here in this study, typical BCR-ABL transcripts. Why is that? Typical means B2A2 or B3A2 transcripts. All other patients were excluded because we are not able to accurately measure deep molecular response with atypical transcripts. And since we wanted to be sure that these patients are in MR4.5, all other patients were excluded. It's important to know the diagnostic BCR-ABL type in order to do the right PCR methodology in follow-up. It does not mean that all patients with atypical transcripts will be excluded forever, but we need the right PCR technology to measure accurately their response. So, result of nilotinib discontinuation, again, the same. 50% of the patients are stable. What is the advantage of nilotinib as a second-generation drug over imatinib? The advantage is that the size of the cohort is different. That means you may discontinue more patients, treatment in more patients than with imatinib, because more patients achieve a deep molecular response as shown here. Look at the 3-year example, for instance. With the 300 milligram BID and the NSND, 32% of patients achieved a deep molecular response, whereas 15% on imatinib. It means the drug itself changes the size of the cohort, but we don't know whether it changes the situation on the individual stem cell. That's still unknown. It may be the case, but we don't know this. So, what about relapse? The patients who relapse, that means 50% of the patients experience a PCR increase more than MMR, and they relapse and they regain response with tyrosine kinase inhibitors. These curves here show how many patients regain MMR. There's 85 out of 86, and MR4.5, 76 out of 86. That's a concern, because 10 patients did not achieve, again, a deep molecular response. I can tell you that most of these patients were nervous, ended the study, and switched to other tyrosine kinase inhibitors. That means there was no risk for life, but they just changed the treatment. Therefore, I don't see a problem with these curves. Again, musculoskeletal pain, also after the nilotinib treatment. A quarter of patients had musculoskeletal pain in the TFR phase. But all the other side effects have improved. Mostly the well-known side effects of nilotinib, like glucose increase, 38 of the patients had a grade 1 or 2 increase of glucose. This was reduced in the discontinuation phase to 18.9%. Although liver function abnormalities, you are experts, you know that, of course, ALT and AST are liver enzymes, and bilirubin is excreted from the liver. Therefore, this is in conjunction with liver function. And you see that 37% of patients had it grade 1 and 2 in the treatment phase, but this number was reduced in the TFR group. That means our assumption that side effects of tyrosine kinase inhibitors will be reduced with discontinuation is true, except the musculoskeletal problems. Molecular monitoring is a key issue for any discontinuation trial. That's very important. It's an institutional requirement which cannot be changed. You need molecular monitoring for proper discontinuation. An early and regular molecular monitoring, detection of MR4.5 as a requirement, or MR4, that's still open, but deep molecular response, and the timely detection of a relapse. And it's not only the monitoring itself, that means labs are available, but the result of the lab should be acknowledged. When you have your 3 monthly visits with the doctor, and the PCR is done on a given time point, and the doctor recognizes the relapse only after the 3 months when you come next, that's not a good situation. That means it should be acknowledged immediately when the result comes back from the lab, and then the doctor should call you and should say, you got an increase of PCR, we should restart the treatment. That means this should be established. This was not the case so far, and if this is not the case, that's an institutional requirement, then discontinuation may be dangerous. So one example how we do it now is my study in Germany. We do it in a multi-center fashion with now 700 patients. We start with tyrosine kinase inhibitor here with nilotinib. We add as a comparator interferon, Y, was explained yesterday by Andreas, and then we have, after a good molecular response, the maintenance phase with interferon, and then we discontinue. This shows an example of a prospective trial which we start a diagnosis with the aim to discontinue treatment. But of course, we look after the patients who will not achieve the discontinuation phase as well. So in summary, multiple studies have consistently demonstrated the safety and feasibility of stopping treatment. It's an emerging goal, and patient awareness of TFR, has resulted in increasing need, but we know that we cannot achieve this in all patients. The sustained deep molecular response and long-term TKI therapy seem to be necessary, but you ask for numbers. You asked me yesterday over dinner for accurate numbers which should go into the ELN recommendations or other recommendations. For the reasons I mentioned, for the institutional requirements and so on, I'm currently rather reluctant, at least until the EUROSTI data are published. But this may be an example. I just put it down here with a conservative view. Prerequisite for safe stopping are institutional requirements for safe supervision. That means to acknowledge the PCR results, to have a PCR lab available which is standardized for deep molecular response measurement. Identification of currently typical B-cerebral transcript at diagnosis. That means when a patient achieved a PCR negativity and the initial transcript was not known, how can you measure accurately the risk of relapse? Therefore, the transcript should be known. At least 5 years, it's a proposal of TKI therapy, achievement of an MR4.5, and the stability of deep molecular response, which is at least MR4. That means there may be some fluctuation for at least 2 years. So, this is my current proposal for the general use outside of clinical trials, but of course this is preliminary. We may discuss this. We need the end data, the final data of the EUROSKI trial with all the statistics in the background, and then we may end up with new recommendations for that. Thank you very much.
Thank you, Professor. Amazingly on time. That's good. We have time for some questions.
Hi, George Sadie from CML Horizon. I would like to ask you here. I would like to ask you, what's the period of time after discontinuing the treatment and you are on the safe side? When you tell yourself that I'm in a safe side, I'm not going to go back, or there is always a risk to go back?
Yes. I think it is shown by the frequency of PCR, the recommendation of the frequency of PCR. Most patients who relapse in the first 6 months, but there are some patients who relapse later. And these patients who relapse very late, after 2 years, 3 years, had a fluctuation before. That means you see a slight increase in the PCR. In these situations, I would recommend a more frequent PCR testing. But you can say if you are 0, that means MR 4.5, and you are still MR 4.5 after 1 year, you are in a very, very safe situation. Yeah.
What's the longest time for a patient, like in your study? What was the longest time for a patient who kept on the safe side? I'm not going to say cured, but who kept in the safe side.
It's now more than 5 years. It's more than 5 years.
Yeah. Questions?
I would like to ask you, what are typical side effects after stopping the treatment?
The most frequent side effects are the musculoskeletal pain. That means you have joint pain, you have a muscle cramp, you have a pain in the bones. That is typical. But there are other side effects as well. We know that, for instance, imatinib has some impact on the endocrine system, on the hormones. That means with stopping, you change the hormone level. I have seen a young patients who got an acne after discontinuation, like at the age of 12 and 13. It looked like. That means there is such situation. Most important is, I think, for the diabetic patients that the glucose level may change again. Not in a dangerous situation, but you should know that. When you discontinue nilotinib, and we know that nilotinib increases the blood level, the sugar level a little bit, you need more insulin, you need more anti-diabetic drugs, then this may be reduced, otherwise you get hypoglycemia. Yeah, and the other situation is with imatinib. Imatinib decreases glucose level a little bit. This may, for diabetic patients, important. It means there's a long list of potential side effects which should be, of course, known. That's the responsibility of the doctor who recommends discontinuation. It should be known.
Thank you very much.
I think one of the interesting things of the EUROSKI study was that there was no plateau, so there were, I think, 1 or 2 people with rising PCR above NMR after 3 years.
Yes.
So how do you see that? Does that actually mean people need to stay on monitoring forever? Can we already tell something? Or were they very regressive in terms of relapse?
I tried to explain this, but for sake of time, it was not possible to bring all the details. I think that's an artifact from statistics. In the STIM trial, the French trial, the definition of relapse was PCR positivity. That means a patient who fluctuated or who had an increase of PCR was positive and was confirmed positive was in the graph a patient who relapsed. Here in the EUROSKI trial, the definition was loss of MMR. That means when you had the same situation as in STIM, you got PCR positive, but on a low level, you were not for the relapse. But then, with this gradual increase over time, you were counted eventually as a relapse patient. Therefore, there was a shift from the early relapse to a later relapse. I think this has no biological background. This is a definition background. It should be known when we compare these curves.
Can I just ask back? I mean, when people read, and probably are not as experienced as you, when doctors read the data, they might think, why should we justify PCR for $100 every 3 months after 3 years of being out of therapy? They would just say, let's save it for the healthcare system. I've heard doctors saying that on stage. What do you think will happen to these patients when they actually have rising PCR, they're no longer monitored?
First, all of you are better informed than the average hematologist worldwide. That's a concern. That's a concern, because everybody now, of course, wants to try discontinuation. But that's my honest opinion. Sounds a little arrogant, but it's my honest opinion. This should be done in experienced centers, which have the institutional requirements. That's very important. And but I forgot your question. No, the cost of PCR. PCR does not cost $400. That's in labs who want to make money. The real cost of a PCR is much less. Yeah. Therefore, it's lower than one non-generic pill per day.
But my question, sorry, then I'm stopping everyone else from that. But what do you expect will happen to the patients that relapse after 3 years and are monitored? Do you think they will progress, or do you think they just fluctuate? Or is it pure speculation?
As long as for the patients who fluctuate on a low level, I think they are still in the same situation. See, there is just one patient in the literature who got a blast crisis after such a trial, but I think this was biology and this was not my opinion, knowing the case. I think in any case, if you restart the treatment early enough, and you re-achieve a deep molecular response, and on the other hand, if you have this low-level fluctuation, you are both in the same situation. That's demonstrated. I think that's what we can say from the current data in the trials.
Okay, this is a very, very interesting topic. Later? Okay. Just to let you know that later on we're going to have a debate.
There are differences between patients with stay with the Gleevec before or nilotinib or the sudden relapse during the Euroscheme.
No, we don't have this data so far. That's part of the data which I mentioned, which we need for the proper recommendation. This has not been demonstrated so far. The difference is just how, as I said, the size of support, and how many patients may be able to discontinue. That's the only difference.